Today's presentation is on diabetes and pregnancy, and this will be presented by Dr. Tejas and Dr. Yasha, both of whom are third year residents at Baroda Medical College. And to help us moderate the session, I would like to welcome ma'am, Dr. Sunita Malik, ma'am. And ma'am has always been an ardent supporter of this initiative that I have started. And thank you so much, ma'am, for helping us reach this far. And ma'am is ex-director professor at Safdarjung Hospital and is currently senior professor at SI Medical College. And thank you so much, ma'am, for being here today and helping these students learn more and more. We also have with us Dr. Shaila Jamal. Ma'am is Professor Unit Head at Sarvodaya Hospital, Greater Noida. Ma'am is also a very she's an excellent academician and has many awards and accolades to her honor. And I'm very glad to have her also with us. So I think we can start today's sessions on diabetes and pregnancy. Dr. Tejas and Dr. Yasha will be presenting jointly. I think Dr. Yasha will start with the history and examination would be Dr. Tejas. So then we can, so this will be like a regular viva, like a long obstetric case we take in the exam. It will be on a similar pattern. So Dr. Yasha, I think we can start.
Thank you, Dr. Raina, for the kind introduction. Yes, we are ready for the case now. Please go ahead.
Thank you, ma'am.
Good evening, everyone. I'm Dr. Yasha, third year resident from Baroda Medical College. Today, we are here to discuss a case on diabetes in pregnancy. I'm presenting a case of 20 years old, female, residing at Vadodara, 12th standard by education and a homemaker. She was admitted in the ward from ANC OPD for deranged blood sugar levels with a known case of gestational diabetes mellitus. Her LMP was 7th April 2023 and her EDD is 14 January 2024. And by gestational age by AMP, at the time of admission, it was 31 weeks, 2 days. The patient was diagnosed with gestational diabetes mellitus at 28 weeks of gestation and started on medical nutrition therapy, that is MNT. She was given a follow-up at 31 weeks of gestation to recheck glucose tolerance. Despite compliance to MNT, the patient had the following glucose tolerance levels at 31 weeks of gestation. Her fasting blood glucose level was 156. After breakfast, 2 hours after breakfast, it was 188. 2 hours after lunch, it was 168. And 2 hours after dinner, it was 190. The patient was, she was not having any history of increased thirst or increased urination, hematuria, flank pain. There was no history of fever, discharge per vaginum. There was no history of blurring of vision, headache, epigastric pain, or palpitation, breathlessness, chest pain. There was no history of abdominal pain or decreased fetal movement. In the first trimester, it was a spontaneous conception. The UPT was positive on 15th day after missed period at home. Pregnancy was confirmed by ultrasound. Anti-scan was done at 11 weeks, which was within normal limits. Dual marker test at 12 weeks was within normal limits. 75 gram OGTT at 13 weeks of gestation was done, which was 120 milligram per deciliter. Her height was 155 centimeter. Her weight was 60 kg and BMI was 24.9 kg per meter square. There was no any history of periconceptional folic acid intake or excessive nausea, vomiting, bleeding per vaginum. There was no history of fever with or without rash, no history of drug or radiation exposure. There was no history of burning, micturition or discharge per vaginum. In second trimester, quickening perceived by patient at 4th month of amenorrhea. 2 doses of tetanus toxoids were given in 5th and 6th month of ANC. History of regular intake of iron and folic acid supplement. Fetal anomaly scan was unremarkable. There was no history of polyuria, polydipsia. There was no headache, epigastric pain, blurring of vision, breathlessness, dyspnea, pedal edema, or easy fatigability. There was no history of bleeding per vaginum or discharge per vaginum. There was no history of recurrent boils or infections. The DIPSI, which was done at 28 weeks of gestation, revealed 2-hour blood glucose level of 196 milligram per deciliter, which is high. The HbA1c level at 28 weeks of gestation was 5.2%, which was normal. Patient was started on medical nutrition therapy with 3 major meals and snacks in between with restriction on sweets. Patient explained regular light exercise. Her menstrual history was suggestive.
Please wait, Yasha. Can you tell me why you talking about that negative history? What do you want to say by that? All the negative history in present pregnancy.
Ma'am, we are
Go
trying
back.
to
Go back. Go back.
Go back one slide. Back. Yeah.
Uh-huh. Before the trimester history, you have given some negative histories, no? Yeah.
Yes, this one.
Yes. What do you
yes.
want to rule out by giving all these negative histories?
So here you want to rule out the various DDs that can present with similar features or the associated complications that can occur with diabetes mellitus. That are if there is hematuria or flank pain, then it can suggest diabetic nephropathy. If there is fever or discharge per vaginum, which is suggestive of any infections, right, like recurrent bacteriuria that can occur, or vaginal candidiasis that are common in diabetes. Then there is no history of blurring of vision, headache, or epigastric pain, which is suggestive of associated PIH, that is preeclampsia. Then there are
How
no.
much is the incidence of associated preeclampsia with diabetes?
It is around 30%. 20 to 30% diabetes mellitus. In diabetes mellitus, 20 to 30% cases can lead to preeclampsia.
Mm-hmm. Okay. What next? Palpitation, breathlessness, next one. Yeah.
Yes, there was no history of palpitation or breathlessness, chest pain, which are suggestive of associated heart conditions which can occur in diabetes mellitus, like ischemic heart disease. Then there were no history
Which
of
cases of diabetes mellitus this occurs? Does it occur in gestational
Pre-gestational,
diabetes?
no in pre-gestational diabetes
overt
mellitus.
DM.
So
There are two
yours is not
cases.
pre-gestational because you just told your history that in first trimester she had normal sugars and now it is increased. That's what you said, no?
Yes,
Yes,
ma'am,
ma'am.
but this is happening in the at the earliest visit in the first trimester. It's
First
always
visit.
advisable to take a detailed history whether the patient. We have to do a risk assessment basically in the first trimester. So if the patient has, we have to calculate the BMI. We should calculate uh, the ethnic group she belongs to. We should also look for any micro or macro angiopathies. So if there is a risk of coronary artery disease, or if there is a risk of nephropathy, neuropathy, if we have ascertained, or we at least have a documentation that in the first trimester all of these have been ruled out at least from a symptomatic basis, then we have a stronger we can make a stronger diagnosis of a over diabetes mellitus as compared to a gestational diabetes mellitus.
Okay, and
Because
then no, that's all right if you don't have any history. But if you have a history, then like it was normal in first trimester, that's what your statement was, and then now it has come now. So less likely to be there. Yes, these things should be ruled out if we don't know the previous history.